Good morning, everyone. I'm Christopher Newman. I'm the chair of the scientific committee of the EACD, and it's my pleasure to introduce this new session this morning. So just as a reminder, please don't hesitate to make this interactive by putting your questions into the chat. I'll be monitoring those throughout the two presentations that are upcoming and really look very promising. Our first keynote lecture is actually going to be the McKeith Press Award Lecture, which is supported by our long-term partner, who's McKeith Press, founded in 1959 by Ronnie McKeith, who really proved instrumental in improving the lives of disabled children and by extending knowledge and the understanding of developmental medicine and pediatric neurology. You can actually see behind me a number of red books, which really count for me in my practice. This lecture is always attributed to professionals who've provided a major contribution in the fields of child disability and/or neurology. And in that sense, it's a real pleasure to welcome Professor Sergiusz Jóźwiak, who is current head of the Department of Pediatric Neurology at Warsaw Medical University. He's not only a very proficient expert clinically, but he's also a very proficient academic with more than 200 peer-reviewed publications. Professor Jóźwiak's research focuses mainly on neurocutaneous disorders and epilepsy, with a very strong focus on tuberous sclerosis complex, in which his expertise is internationally recognized. He actually participated in the discovery of the TSC1 gene. He has developed practical guidelines for the management of the pathology, and other interests outside the the TSC domain are multiple sclerosis, neuromuscular disorders, as well as metabolic diseases. He's received several awards up till now, among which the Polish Academy of Science Award and the Manuel Gomez Award of the Tuberous Sclerosis Alliance in the USA. And I think what they said says a lot about Professor Jóźwiak. It was basically for his creative and pioneering efforts that have appreciably improved either the understanding of the disease or the clinical care available for individuals with tuberous sclerosis. Now, today, we're going to be talking about something different, a subject which is of concern to lots of the attendees of the EACD meetings. You are going to be talking about cerebral palsy from a pediatric neurologist's perspective. Professor Jóźwiak, the audience is yours.
Thank you very much, Chris, for this introduction. I feel better because indeed, I am working in epileptology. I am working in tuberous sclerosis. I am not so much working with cerebral palsy, but as a practitioner and a clinical neurologist, I have a lot of patients and I have my own comments on cerebral palsy as well. I would like to apologize if some of the parts of this presentation will be rather superficial for many of you experts in the field. But I think this presentation will be also a little bit inspiring, and I'll give you a new idea, even as a person working not directly with cerebral palsy, but in the field of pediatric neurology. We can go further. Okay, this way. I have no disclosures to disclose, nothing to disclose. I will be talking on epidemiology, definition, etiologies, early diagnosis, epilepsy and neurocognition, and the relationship and the communication between neurologists and doctor and parents. So in fact, it is the whole spectrum of the work with cerebral palsy patients. That's why some parts will be not very deeply studied and discussed here. But I did my presentation on the recent literature, and I hope it will be interesting. Let's go further. So epidemiology of cerebral palsy is a leading cause of motor disability in children, with the prevalence rate 1 to 4 per 1,000 live births. And this rate is about 2 per 1,000 live births in Europe and North America, despite the increasing survival of extremely premature infants, and a little bit higher, 3 to 4 per 1,000 live births in low to middle income countries. Of course, due to poor access to quality prenatal and perinatal care, rehabilitation programs, environmental support. This rate is about 6-fold higher for infants born between 32 and 36 weeks estimated gestation, and 30 to 70-fold for infants born prior to 31st week compared to infants born at term. Just a few words about the evolution of cerebral palsy concept, starting from the end of 19th century, who ascribed asphyxia at birth and associated to permanent central nervous system damage. Osler in 1889, who introduced the term cerebral palsy of children as heterogeneous group of disorders. And recent definition, cerebral palsy as a group of permanent disorders of the development of movement and posture, causing activity limitation that are attributed to non-progressive disturbances that occurred in the developing fetal or infant brain. It is interesting also the new concept of cerebral palsy as a cerebral palsy spectrum disorder, similarly to autistic spectrum disorders. This term just highlights the challenge of categorizing such a large group of disorders that are both etiologically and phenotypically heterogeneous. In the definition we are talking that it is a permanent disorder, but permanent is injury. Still some comorbidities of cerebral palsy, effects of this injury may change over time. So it's also very interesting because very often parents are asking us, doctor, on brain MRI we have some changes now, but it was not everything okay in the first months of life. So the effects of this injury may change in time. So like appearance of this porencephalic cyst on MRI or ultrasonography, as the development of contractures in untreated patients with CP with the injury, brain injury. So injury is permanent, and still the effects of the injury may change depending on the management we are carrying out, depending on different aspects. So etiology, of course, we divide usually this triggering factors to prenatal, perinatal, and postnatal factors, with different aspects working in these particular periods of life of the child, with additional impact of developmental disorders, and I will be talking also in my presentation about genetic findings. So all these aspects result in motor and cognitive disabilities, which may be observed in cerebral palsy children. I think 20, even 10 years ago, we considered cerebral palsy as a non-genetic condition in majority of cases. Still, the recent papers and the development of genetics during the recent decades just shown up that this genetic etiology may be suspected in up to 30% of cerebral palsy cases. So it is something very interesting, the development of genetics in medicine in general, but also in this field, in these patients. During this many years of cerebral palsy in existence in the medical literature, of course there were developed many classifications. Probably these classifications are more popular depending on differently in different countries. In Poland, we are often pediatric neurologists at least are using this Ingram classification into diplegia, hemiplegia, bilateral hemiplegia, ataxia, dyskinesia, and mixed types. Of course, there is a little bit simpler classification like Hagberg's classification to spastic syndromes, extrapyramidal syndromes, or ataxia. And on this graph, you can see also this all this classification on one graph, just demonstrating this Ingram classification and this Hagberg classification. We may divide also these cerebral palsy children into severe, mild, or relatively the normally developing children. So the severity of disease of disorder may be also assessed separately. When we are talking on the prevalence of these cerebral palsy subtypes, there could be some differences depending on the institution which is doing this analysis. But usually the most frequently recorded or reported type of cerebral palsy is spastic diplegia with 35% of patients, 25% with spastic hemiplegia, 20% with spastic quadriplegia, 15% with extrapyramidal signs, and 5% other types of cerebral palsy. There are multiple factors which are increasing risk of cerebral palsy in fetuses and in children with this disease, with this disorder. So congenital brain malformation, genetic susceptibility, hypoxic ischemic encephalopathy, some in utero or perinatal stroke, in vitro fertilization, kernicterus, now it's probably less appearing, low birth weight, important factor, and long list. I will not be reading this all factors which are certainly very well known to you. As a clinician and pediatric neurologist, we very often receive the information about the perinatal status of the child and we are using Apgar score. What is the importance of Apgar score? It is a question which is often asked. From my perspective, and also from this very interesting paper from Sweden, just recently published in 2018, the most important and predictive for the development of cerebral palsy is the Apgar score at 5 and particularly 10th minute. So the conclusion of this paper was that a reduced Apgar score at 10 minutes confers higher risk of cerebral palsy and epilepsy than does a reduced Apgar score at 5 minutes. And even slight changes with normal Apgar score also influence the possibility of development of cerebral palsy. So I think it's very interesting paper just documenting what we suspected when we obtained the message about the Apgar score in our patients. We need to move to the next slide. Okay. Of course, we know that cerebral palsy children need early diagnosis, and there are important notes also. Despite of historical calls in the literature for early diagnosis of CP, the diagnosis still often occurs late, from 12 to 24 months in high-income countries, and as late as 5 years in low-resource settings. And it may be important to identify children who are at substantial risk of CP as early as possible. And an example, so from the Australian Cerebral Palsy Register report from 2018. In Australia, only 21% of infants receive a diagnosis by 6 months of age, and 52% have a diagnosis made after 1 year of age. So it is still an insufficient number of patients with early diagnosis of cerebral palsy. So why we should diagnose cerebral palsy early? This early diagnosis allows access to cerebral palsy specific early intervention. Early physiotherapy ensures better results due to higher potential of brain plasticity, and also, which is very important, that very often we don't tell about that. It's much easier to carry out physiotherapy in the first 6 months of life than in older patients who are fighting with the physiotherapist. Also, this early treatment allows timely psychological support for parents, and also give more time to parents also for acceptance of the diagnosis, and for better communication between the doctor and parents. We need to stress importance of ultrasonography, CT scan, MRI in fetal brain assessment, and generally in infant assessment. Even in fetuses, when we are talking about the fetuses, we are able, with the use of ultrasonography, which was incorporated into obstetrical practice by Ian Donald in 1953, and enabled detection of brain abnormalities in utero, we may diagnose these fetuses in different brain malformations. Of course, introduction of CT and particular MRI in the 70s and 80s last century helped us significantly to diagnose brain abnormalities and different changes, different brain lesions, and to diagnose much earlier cerebral palsy in patients. So CT and particular MRI enabled better structural assessment of fetal brain, and American College of Obstetricians and Gynecologists in 2016 recommended MRI such evaluation, allowing intrauterine surgeries for conditions like hydrocephalus. It's also very big progress in this intrauterine surgeries during the recent years. Another interesting paper, according to American Academy of Neurology, after review data of 1,426 children with cerebral palsy, 62 to 100% of individuals have abnormal neuroimaging. It is a little bit more, MRI is more sensitive, 89% of positive results, and CT was a little bit less, but still very high percentage of positive findings, 77%. With MRI findings and particularly with the higher resolution MRI, we may see very well different, even the layers of in the brain. And it's you can see depending on different kinds of cerebral palsy subtypes, we may see very different changes. Unilateral spastic hemiplegia, we may see focal vascular insults, mainly malformations, unilateral hemorrhage, also sometimes this middle artery cerebral artery stroke with asymmetry of myelination. But in bilateral spastic diplegia, bilateral white matter injury is the most frequent. In bilateral spastic quadriplegia, which seems to be the most severe usually in those patients, we may observe gray matter injury in 34% of patients, malformation, cystic periventricular local malacia with absent myelination, and severe white matter injury with or without deep nuclear gray matter. So the introduction of MRI into the diagnosis, in the application of this diagnostic tool made a significant progress in the diagnosis of cerebral palsy. Here is very interesting paper. It is a multi-center international study, and in fact, this paper published in JAMA Pediatrics in 2017 is a kind of guidelines for early intervention in cerebral palsy. The authors did a search in which included systematic reviews with or without meta-analysis, and analyzed criteria of diagnostic accuracy and evidence-based clinical guidelines. And they recommended some kinds of diagnostic tools depending on age of the patients. They recommended that in infants, clinical signs and symptoms of cerebral palsy emerge and evolve before age 2 years. Therefore, a combination of standardized tools should be used to predict the risk in conjunction with clinical history. And in children before 5 months of corrected age, the most predictive tools for detecting risk are MRI with 86 to 89% sensitivity, qualitative assessment of general movements, 98% of sensitivity, and Hammersmith infant neurological examination, 90% sensitivity. There is a slightly different triad of these diagnostic tools after 5 months of corrected age, with the most predictive tool for detecting risk, MRI, again, similar sensitivity, 86, 89, and Hammersmith infant neurological examination, but appeared a new diagnostic tool, developmental assessment of young children. So it is a combination of the tools which are recommended for the diagnosis of infants with cerebral palsy by this group of authors. It is interesting paper, just as a comment to this published guidelines from 2017, because 5 centers from United States just analyzed the change in the frequency of diagnosis of cerebral palsy in their institutions during 1 year. And they found that before the introduction of these guidelines from 2017, the average age of cerebral palsy diagnosis in their institution was 19.5 months. And this age decreased to 9.5 months in 1 year after introduction of these guidelines. So it's a very positive move in the average age of the diagnosis of cerebral palsy in this institution. So it's a good example of this implementation of the guidelines. The authors who wrote the guidelines in this group in 2017, they just published this year again a further study. Systematic overview of best available evidence interventions for preventing and managing cerebral palsy using GRADE and the evidence alert traffic light system. 1,546 articles were reviewed, and the authors presented the results in a kind of red, yellow, and green lights, just differentiating the tools to those recommended as a green light, with some positive effect as a light, yellow lights, and these red lights, which is not recommended, not useful, not effective. So it is very interesting presentation. I am not going to go deeply. It wouldn't be visible here on the screen. So I refer you to the paper which was published this year very interesting, and it's interesting to discuss. And certainly there are differences also in different countries. When we are talking about cerebral palsy, there are significant differences in the methods we are using in different countries. And I think, I don't know, certainly I think you were discussing during your meetings this issue, and still a lot of work should be done just to compare the usefulness of these methods. For example, in Poland, we are often using Wojta method, which here is considered as not effective. We are using also NDT method, Bobat method, which seems to be more effective, but still, again, it could be a discussion about that. So I think it could be a very long discussion, and for some period of time as well, I was also the head of the pediatric neurology department with a part of a rehabilitation center. And it would be interesting to make a longer and probably multi-center studies just to compare the different effects as well. Okay, let's go further. So conditions associated or comorbidities of cerebral palsy, epilepsy, SUDEP, sudden death due to epilepsy, intellectual disability appearing in 40 up to 60% of patients with CP, depending on type, malnutrition, speech problems, hearing impairment, visual impairment, sleep disturbances. There is a long list of different these comorbidities, different problems of the child with cerebral palsy. So of course, such patients needs a multidisciplinary team with the pediatrician, neurologist, occupational therapist, audiologist, social worker, orthopedist, psychological speech therapist. This team should be personalized and designed according to the needs of the patients. I would like to stop for a while on epilepsy and intellectual disability in this group of patients. So epilepsy appears, of course, differently with the different incidents depending on the type of cerebral palsy. So tetraplegic or triplegic cerebral palsy patients have 50 to 90% of them have epilepsy. Hemiplegic, 30 to 50% of patients. Ataxic, 16-27%. But still, so it is a relatively high incidence of epilepsy, high frequency of epilepsy in this group of patients. And what would be implication of epilepsy in such patient? So sudden interference with movement patterns, posture can be devastating in an ambulant child whose mobility is already impaired. And cognitive and educational goals are more difficult to achieve, of course. So it's a little bit my own concept and idea. Is there a need for epilepsy prevention in some selected patients with cerebral palsy? So I will try to demonstrate you the concept we are using for tuberous sclerosis patients. So just 10 years ago, 20 years ago, of course, even earlier, we were taught that we are treating patients with epilepsy when we have just at least 2 seizures, even not 1, but even 2. Now the concept changed and we have recommendations. We can treat according to the current definition of operational definition of epilepsy. We may treat epilepsy after 1 seizure and probability of the second more than 60%. But yet 10 years ago, we were treating only after 2 seizures. So it is the seizure and there is normal time of treatment after seizures. But the seizures, the epileptogenesis, the process of developing epilepsy starts before the first clinical seizures. So this is called the latent period of epileptogenesis. And the triggering factor, which could be a stroke, which could be perinatal asphyxia, brain malformation, brain injury. After this insult, there is a time of developing. There are developing some changes in the brain, leading to clinical seizures. So there are some concepts, whether we shouldn't look for beginning of epilepsy in some selected patients with high risk of epilepsy and to start treatment of those patients a little bit earlier. Oh, sorry, this way. And in fact, the first trials of preventive treatment in patients with some perinatal problems, the first trial was done by Birgit Walter, who in 87 published her study. She studied polygraphic tracing of 941 newborn infants in a prospective study, 18 infants. She found that 18 infants suffering from perinatal distress and 7 newborns with malformations of the brain were scored positive according to their scoring scale, and all developed infantile spasm and hypsarrhythmia. And she proposed pre-onset treatment preventing secondary mental deterioration due to hypsarrhythmia and infantile spasms. So it was the first concept, but still lost. It was too revolutionary idea at that time in 87 to do anything with the child who doesn't have any epilepsy at the clinical seizures at this moment. So it was completely forbidden. In 2011, we published our short paper on tuberous sclerosis. We compared the effects of the treatment with vigabatrin, the drug usually used for tuberous sclerosis patients, and the results of the treatment of 2 groups of patients with very early diagnosis of tuberous sclerosis, prenatal, so newborns, or infants, very young infants before 4th month of life, before the usual time of developing of epilepsy in those patients is 5th month of life. We follow those patients from newbornhood till 24 months of age. And in the standard care group, we just follow those patients. We didn't carry out electroencephalography and treated when they had clinical seizures. And in this group, 9 patients didn't develop epilepsy and had normal development. 22 patients developed epilepsy, and 15 of them had intellectual disability, 48%. So half of them had intellectual disability. In the preventive treatment group, we had, sorry. Okay. I need next slide. Okay. In the preventive treatment, we have 14 patients. We had 14 patients who had electroencephalography every 4 to 6 weeks. And in this group, when we observed paroxysmal epileptic activity on EEG, on subsequent EEGs, we started to treat with vigabatrin with normal dose, so preventively those group of patients, and we followed them till 24 months of age. In this group, 4 patients didn't have any abnormality on EEG. They were not treated. They had normal development, and 10 patients were treated due to abnormal epileptiform activity. And 6 of them developed epilepsy, and 2 only had mild intellectual disability. Okay, sorry. So there are just the comparison of this preventative group and standard group. We had much less drug-resistant epilepsy in this preventative group, and we had more seizure-free patients, significantly more seizure-free patients in the preventative group, and much better development. Here it is the most important line. We had no patients in this preventative group with severe forms of intellectual disability. So it was the most, it was target for us at that time. So just this month, in fact, We published the results of EPISTOP trial. It will be available soon in Annals of Neurology, when we showed in the group of 100 patients, it was a randomized double-blind study. We demonstrated that this preventive treatment may decrease the number of patients with epilepsy and may improve the cognitive development of those patients. So is there a room for such approach in cerebral palsy? It's certainly a question for discussion, and certainly it should be necessary to develop to select particularly those groups with high risk of epilepsy development, not for every patient. Perspectives of parents, what they are expecting from us. They expect from us early diagnosis, more personalized information about their own child. Of course, they very often want to discuss the MRI results and the relationship of these results to the prognosis of cerebral palsy, and they expect a guidance on best interventions in these patients. So there is a proposal to use acronym SPIKES to talk with parents. SPIKES, as setting up the interview, P, assessing the family's perception, I, obtaining the family's invitation, K, give knowledge and information to the family, E, addressing the family's emotions with empathic responses, and S, to describe the strategy and summary. And I would say that the communication with the parent is the key, and their understanding what we are proposing, what we are proposing them, what kind of management, it's essential for a good development of the child, for their collaboration with us. So it is very important. There is a short overview of different management in cerebral palsy. I will just show you the physiotherapy. Of course, we have different methods we are using. Just the aim is to prevent or reduce the contractures. As I said, we are using in Poland very often NDT and Wojta method. It's the most frequently used, I think. Other methods of spasticity treatment with sensory integration, also deep brain stimulation, hyperbaric oxygen therapy, which is regarded as completely ineffective and not useful, but still sometimes proposed. Pharmacological treatment, I think when we are talking about pharmacological treatment, it's the relatively common agreement. We may use an oral baclofen or diazepam, intrathecal baclofen for some very selective patients, and botulinum toxin, of course, as well in those patients. And some surgical treatment of spasticity. Here, Professor Jóźwiak would say much more, so I will just go further. And what is interesting, just the recent years, some trials with the stem cell treatment. Still, from my practice, we also had patients which was injected with stem cells, but the problem of injections is that we need to go directly to the ventricles. The stem cells given to the blood are not effective. I am almost finishing now. The outcomes, we need to remember that the patients may and should live very long with patients with cerebral palsy. So these deaths attributed to cerebral palsy per se are very rare. And I think one of the last slides, cerebral palsy and COVID. Adults with CP have a greater risk of respiratory disease than adults in general population. 35% of children at the age of 5 to 12 years with CP couldn't perform the task of breath holding. And there is a higher risk to progression to severe COVID-19. And summary, cerebral palsy is usually associated with the involvement of many systems, which is why multidisciplinary care is necessary. Early diagnosis allows access to CP-specific early intervention and allows increased family involvement in treatment, and introduction of international guidelines in 2017 for early detection decreased significantly age of CP diagnosis. The most important role in the prevention of CP is played by the reduction of prematurity and low birth weight, and new approach to epilepsy prevention may be discussed in selected CP forms. Patients with cerebral palsy are at increased risk of severe COVID-19. So thank you very much for your attention, and I suppose my talk was a little bit too long. I apologize for that. Thank you.
Thank you very much, Sergiusz, for a very comprehensive and up-to-date overview of cerebral palsy. We can take just maybe a few minutes for a couple of questions and answers. So yeah, please, to all the participants, don't hesitate. You can throw your questions at us. But before they arrive, maybe one question I have, you talked about communicating with the parents and basically also giving them the diagnosis. Do you have any thoughts on how we should discuss about the diagnosis with the child when he grows up? Because I think that's an aspect which is often overlooked. And what is your role as a pediatric neurologist, and then discussing around the diagnosis when the child is older and when he's able to understand what happened to him?
Fortunately, we have very good some examples of possibilities, and different sportsmen who are really doing very significant efforts and have successes despite of their limitations. So I think it's a very good example of how we can cope with disability, and I think it is the best suggestion and best example for such youngsters, for younger patients. And I think the example is the best motivation.
So a few questions from the audience. Do you recommend for pediatric neurologists controversial methods such as VOITA, neurodevelopmental therapy, sensory integration, where if you look at the probably red light, yellow light, green light system, there's a pretty low clinical evidence rank?
Yeah, I think it's a big role for persons and for such community as yours and ours for comparison the methods used in different countries, because still there are big differences in Europe between countries, and it's not possible to change, just this way the methods. I think we need to discuss that. We need to talk and to teach the physiotherapists. We need to teach also pediatric neurologists about new methods, and step by step change our approach to the treatment of the cerebral palsy. I remember, as a member of educational committee of European Pediatric Neurology Society, I also visited Monachium, München, and I was talking to the professor of pediatric neurology there, and he was a professor of rehabilitation as well. And they don't use VOITA method, which came exactly from München to Poland, and which is quite developed in Poland.
Thanks a lot. I think that, well, sadly, we have to close now for these questions. It was a real pleasure being able to exchange with you. I have the difficult role of actually being the timekeeper as well as the moderator. So, but no, again, a very, very big thanks for this comprehensive overview of cerebral palsy. And I do hope that myself, as well as the other participants in this EACD, will be able to meet up with you at some later stage in the future directly. So thanks a lot, Sergiusz, and congratulations and all the best for the future of your work.
Thank you. Thank you very much. Thank you very much.